A common question that I receive sometimes in my feeds and from patients is, Dr. B, what do you do about chronic wounds? This is a very challenging topic. I'm Bienstock, and I'm a board-certified plastic and reconstructive surgeon. My expertise and interest is managing wounds in the house, particularly that are chronic, for those that are homebound and bedbound. Today, we're going to talk about chronic wounds. This is kind of the bread and butter of what I see in my practice. Very rarely do I get consulted on acute wounds. It does happen. I usually get consulted on chronic wounds. And these can be very, very challenging, both for vascular ulcers, pressure ulcers, traumatic wounds, because all the strategies that have been done before are really not working. And this is why I get called in. So what do you do with chronic wounds? Well, a lot of it, as we talked about in the previous session, what's causing the wound to begin with? Is it pressure? Is it traumatic? Is it vascular? So that's the first thing we have to address. So we'll talk briefly about pressure ulcers. So a lot of the times, pressure ulcers don't improve because, number one, we're not eliminating pressure. We won't go over ad infinitum, as we've done in previous videos, about pressure relief. Your loved one has to be turned every 2 to 3 hours, nonstop. We have to minimize sitting if it's on the sacrum. Secondly, a lot of times we're using gels or ointments that add moisture. We want to make sure the wound is being dried out. 3, sometimes we have what's called involution of the wound edges. So I call this, you want the skin edges kissing. So I tell my patients when the skin edges are going down, or like the boy is looking at his feet, he's not gonna be able to kiss a girl. It's very hard to kiss a girl if you're looking at your feet. A lot of times the wound edges involute, or they go down, and that will stall the wound. It tells the body we're healed, but we're not. So in those scenarios, you have to do a surgical debridement. You want to clean up those edges to get rid of those edges that are going down and create them to go this way. So that's number one. Sometimes we have to scrape or debride the base of the wound to stimulate new tissue growth, or what we call angiogenesis, meaning new blood vessels to grow. One of the other things we have to do is make sure there's adequate nutrition. We've talked about nutrition ad infinitum as well, in terms of protein, collagen, L-arginine, zinc, vitamin C, which you can refer to other videos. So a lot of those have to be optimized when I see patients. One of the things that commonly with chronic wounds is that the person is not receiving enough L-arginine. That's been a game changer. I have 2 patients that the wounds were not healing for over a year. We started adding L-arginine very aggressively to their diet and their lifestyle, and this really jump-started their healing capacity, in addition to everything else. So as I was talking about, a lot of times people are using the same wound treatment, whether it's an alginate dressing or a gel or an ointment, to these chronic wounds. Those type of things don't work. You have to get into more advanced wound care after we've done the debridement. So a lot of times I'll use collagen dressings such as Epione or Prisma. Now in certain scenarios when it's a chronic wound and it hasn't responded, I will use something called a biologic, or I recommend a biologic graft or skin substitutes, which we'll talk about in another session. These generally come from amniotic tissue or placenta tissue, and they really have helped my chronic wounds, and it's been miraculous in some of my patients. I had one patient who had a wound on the sacrum for 2 years. Nothing worked. I did multiple debridements, we did oxygen therapy, and we started doing a skin substitute called Wound Fix. And after 7 sessions, the wound was almost healed. After 9 sessions, it was 99% healed. Nothing else would work. So those are times where skin substitutes are really great. There's a lot of controversy about skin substitutes, which we'll talk about in another episode. Another thing I like to add to the panoply of treatments for chronic wounds is something called oxygen therapy. Now, you may have heard of hyperbaric oxygen, or going to a hyperbaric chamber. A lot of my patients are homebound and bedbound, so they can't go to an institution that has this big chamber that gives extra oxygen, which increases what's called the AO2, or the oxygen concentration, which helps new wound tissue growth as well as new nutrients going to the wound. So another alternative is something called topical oxygen therapy, and that's just what it says. You're basically delivering high-dose oxygen via bag. You're basically attaching a bag with adhesive to the wound and hooking up to an oxygen tank and delivering large amounts of oxygen to this wound 4 times a week. And this has really been a big game changer in my practice, and it's really helped a lot of my chronic wounds. I've healed a 101-year-old woman with this who had a chronic sacral wound for 2 years. So there's no simple answer to these type of wounds. You know, when it comes to vascular wounds, it's the same thing. You have to make sure that we're addressing the issue, make sure there's adequate arterial blood flow, and you have to change up the dressings. You don't want to be using the same boring dressings such as Manuka honey or alginate dressings. You have to really look at those that are better for chronic wounds, such as collagen products. There's silver collagen gels as well, and the last resort would be skin substitutes. When it comes to traumatic wounds, there obviously can be an issue with it. The wound needs to be debrided. A lot of times I've seen orthopedic surgery patients who had a hip replacement have an open wound and it's not healing. A lot of the times they're just using bacitracin and other ointments that are really not meant for chronic wounds. A lot of the time I'm able to heal these wounds just with a nice debridement and changing the wound care into something that's more positive, such as a collagen dressing or something called hydroferroblue to really clean it out. We'll go over hydroferroblue in another session. But I want to reiterate once again, chronic wounds are very challenging. It's challenging both for myself as well as nurses. you have to change the status quo. If the same thing that you're doing is not helping the wound over a year or 2 years, you have to change it up. Surgical debridement and scraping, making sure adequate turning, adding more supplements such as L-arginine, NAD+, NAC, high-dose vitamin C, magnesium, looking at oxygen therapy if insurance allows it, as well as looking at skin substitutes. And sometimes patients do require a new bed, such as a Clinitron bed or a Group 3 bed, which we'll talk about in another session. So I want to reiterate once again that these are really challenging wounds. It's part of most of the wounds that I see in my practice. I'm happy to entertain any questions or comments you have about chronic wounds in terms of treatment management and diagnosis. Please make sure you subscribe to the channel and make sure you share the channel, and I look forward to our next session. Thank you so much.